I'm going to be speaking about Parkinson's disease and essential tremor. So first I want to talk about how common are these diseases. So the most common movement problem in terms of tremor is a physiological tremor. So if you see in this graph, movement disorders that are common, restless legs and Parkinsonism. Parkinsonism includes Parkinson's disease. So Parkinson's disease is characterized by specific features that I have put in this diagram. So as you see, this individual has something that we call stoop posture. So his posture is a little bit forwards, okay? That's what we call stoop posture. Rigidity and tremor are also important characteristics. So here I have listed the most important characteristics of Parkinson's disease: tremor, rigidity, akinesia, which means decreased movement, and postural instability. So those are the key features of Parkinson's disease. So how common is it? There are more than 100,000 cases in the United States. And there is a male to female ratio of 3 to 2. So in other words, it's a little bit more common in men. And the age of onset is between 50 and 60 years of age. But of course, some patients can develop it before or after this age. And there are about 50,000 new cases a year in this country. Okay, so here I put a picture of two brains. A normal brain and a brain with Parkinson's disease. So this is a part of the brain only, okay? In this part of the brain, in patients with Parkinson's disease, something that is called the substantia nigra, there is part of the brain that is a little bit dark, is lost. So this is a normal patient, and this is a patient with Parkinson's disease. You can see how that substantia nigra has been lost here. This area of the brain produces normally dopamine, and dopamine is a very important neurotransmitter. So it's a substance that transmits impulses in the brain, and we all need dopamine. So when dopamine is decreased, like in this case, there is less signal to the rest of the brain. There is less signal of dopamine, and therefore the patients will develop the symptoms that I was mentioning: tremor, rigidity, and decreased movement and balance difficulties. Here I'm listing the two types of symptoms that occur in Parkinson's disease. So I mentioned these ones: tremor, rigidity, decreased movement, that is also called bradykinesia, postural instability, and also one that I didn't mention before that is called gait freezing. And that, how the way the patients look is they start walking and all of a sudden they freeze. They can't lift their feet off the floor. That is called gait freezing. So this group of symptoms, we call it motor symptoms because they have to do with motion. Now, there are non-motor symptoms as well that I hadn't mentioned before, but the truth of the matter is that Parkinson's disease is a disease of a very wide spectrum. It causes a lot of symptoms. So the non-motor symptoms include everything that we cannot really see on the patient's motion, meaning cognitive impairment. That's something that is not visible, that you understand when you interact with the person. Mood disorders such as depression, apathy, problems of impulse control, sleep problems.
That's a big one, yeah.
Orthostasis, that is characterized by feelings of dizziness when the patients stand up. So when you stand up, the blood doesn't go to the brain but just goes to the legs, and their body doesn't have the capacity to control for that loss of pressure, and therefore they develop dizziness. And constipation is another important non-motor symptom. And this slide is just to show you a little bit in more detail examples of non-motor symptoms. So as I was mentioning, the blood pressure control could be lost, and therefore when patients stand up, they can feel dizzy. because of the sudden loss of blood pressure. Constipation, decreased appetite, and weight loss. Bladder symptoms, these ones I didn't mention before, but really the spectrum is so wide. Urinary incontinence, frequency of urination and urgency, and in some cases even incontinence. To continue with the non-motor symptoms, I was saying the cognitive ones, thinking and memory problems, difficulty with planning things, multitasking, remembering, even following conversations. Mood changes include patients that are feeling sad, anxious, or very restless. And also, commonly, patients in late stages can develop psychosis, meaning hallucinations. It's very frequent that we also encounter fatigue. Patients feel very, very tired, and there is really not a specific treatment for that. It's difficult to manage when patients are so fatigued. Difficulty sleeping, and I also mentioned vivid dreams that can lead to patients falling out of bed because they are acting out their dreams. So who can diagnose Parkinson's disease? So usually primary doctors, when they see that there are symptoms that look like the patient could have Parkinson's, they refer patients to a neurologist to make a definite diagnosis. And at some point, neurologists can also refer patients to a movement disorder specialist, someone like me. We're in the third floor at the Neurological Institute. We're all movement disorders doctors, so we focus on very specialized treatment of patients with Parkinson's. The patients with Parkinson's not always need a movement disorders doctor. A movement disorders doctor is a neurologist who only focuses on that subfield. But when there are difficulties in the treatment, or if the patient prefers to have a more focused care, then the patient is referred to a movement disorders doctor. The gold standard for the diagnosis continues to be the clinical exam, okay? However, there is a test called a DAT scan that will give us information about the amount of dopamine. Remember I showed you those brains where there was decreased dopamine? So there is a test called DAT scan that will tell you that in someone normal, there is the amount of dopamine. You see a lot of light. And here there is decreased dopamine. That's how it will look in a patient with Parkinson's. But when we have patients where the diagnosis is very clear clinically, there is no need to do this, because this is not going to give us more information than what we already have as physicians examining the patient. So this test is usually not necessary and puts patients through radiation and injection of contrast that may be even harmful. How do you treat the Parkinson's disease? Parkinson's disease, we usually treat it by supplementing dopamine in the form of levodopa, also commonly called the Cinemet. So this is the most commonly used medication. And the rest of medications try to do the same. So try to increase dopamine in many other ways. It could be more indirect or more direct, but that is at the end what we are trying to accomplish. So we can also use dopamine agonists. They are more specific and they stick to the dopamine receptor to activate the receptor. These are some of the examples of the names of those medications. MAO inhibitors, that what they do is they increase the amount of dopamine because they block the enzymes that destroy dopamine. So if you block those enzymes, you're going to have more dopamine available in the brain. Amantadine, to this day, we don't know why it helps patients with Parkinson's. There are many theories, but we don't really need, that's beyond the spectrum of this talk. And anticholinergics that also indirectly increase the amount of dopamine. Examples of anticholinergic are medications such as the Artane or trihexyphenidyl. For all these medications, the doctor is the best person to judge because we have to take into account potential side effects, the stage of the disease, and when do we need to actually stop them because they could be causing some of the problems at some point as well. In terms of the levodopa, what are the side effects? Because every medication, including Tylenol, is going to have side effects. And I'm sure that you have seen when you pick up something in the pharmacy, they give you a paper that when you open it, it has so many side effects that they are very scary. So I think doctors are also the best judges to say when someone is a candidate for a medication and when it needs to be decreased, because we remember all of these potential situations and we put it into context when we see patients. Cardiovascular, so levodopa itself can also cause orthostatic hypotension, and remember that was one of the non-motor symptoms, that the blood pressure can drop. So levodopa can also cause that, usually in very high amounts, not small amounts. Neurological side effects including agitation, anxiety, confusion, dizziness, hallucination, impulse control disorders, nightmare, somnolence, and dyskinesias. So if you see, a lot of this were already symptoms of Parkinson's. So if we give patients levodopa, at some point they may even worsen from those symptoms. So we have to always be very vigilant about the potential side effects.
Do they go away after a period of time?
Depends on the symptom.
So
usually if we decrease and the individual, if you decrease the amount of medication, they can possibly go away. Gastrointestinal, usually patients can notice that the appetite is less. They often can develop a little bit of diarrhea, nausea usually in the beginning, but that usually goes away. Sialorrhea, meaning drooling, and vomiting. But there are tools that we use to try to decrease these gastrointestinal side effects and help patients tolerate the medication better. So now we're going to switch a little bit and talk about essential tremor. So essential tremor is another different disease than Parkinson's that also causes tremor. It is also known as benign tremor or familial tremor. So usually there are family members that already had tremor and they pass it on to their kids. So it's usually it's around in the family. It just causes a part of your body to shake uncontrollably and is usually affecting the arms and forearms, but in some cases can also affect the head and the legs and even the voice. As any tremor, it worsens with stress, drinking coffee, and when patients are fatigued. So in terms of the treatment for essential tremor, there are some medications that can be helpful. They are unfortunately not always well tolerated. Propranolol, for example, we use it to control the tremor but can cause drops in blood pressure. Primidone is an anti-epileptic medication that causes a lot of sleepiness but is good to treat the tremor, so if the patient can tolerate it, it could be a good medication. And also Xanax and topiramate have been used to treat essential tremor with good results. Now I'm going to talk a little bit about what I do specifically, which is deep brain stimulation. And deep brain stimulation is an FDA-approved therapy. It's not a research treatment for Parkinson's. It is actually already FDA-approved for more than 20 years. So it has been approved for the treatment of essential tremor, Parkinson's disease, and other conditions. And there is research on the use of this therapy for other situations. But these indications are still not FDA approved. Only essential tremor and Parkinson's disease are FDA approved to use deep brain stimulation. So before deep brain stimulation, what doctors will do is cut a part of the brain, you see here, they cause a little small damage to the brain. So that will make the tremor go away. Of course, this was very invasive because you are actually damaging a part of the brain. After 1997, when the FDA approved deep brain stimulation, we were now able to place a lead. It's like a small cable deep inside the brain, okay? And that is put in through a small hole made in the skull, through which we put in the DBS lead. The small hole is the size of a dime, so it's a very small hole through which we put the DBS lead or the wire. And that wire has extensions that go through inside the skin, through tunnels, to the upper chest, where we put the battery and connect those cables. And therefore, when we turn on the battery, we're able to stimulate the brain. The battery looks like when someone has a pacemaker, so it's nothing that you see from outside. The good about this is that we don't need to cause a brain lesion. We don't need to cut the brain like the slide I just showed you before. We put it in something, and with electricity, tiny amounts of electricity, we can replace that dopamine that the patient doesn't have, or at least the activity that the dopamine was doing to the neurons, and therefore decrease the amount of tremor and stiffness and changes in movement. This is the DBS lead that has 1, 2, 3, 4 contacts. So that gives us a lot of flexibility to program the patients, because you can choose to turn on 1 or 2 or 3 or 4 or different combinations of them depending on where in the brain it ended up, how close it ended up being to where you want it to be. This is an example of what DBS would do for someone with essential tremor. So this is the patient with tremor trying to make a spiral before the surgery. And this is the patient after the DBS surgery. So you see how the tremor has decreased and the hand is much more steady. So this is what we could do for patients with either essential tremor or Parkinson's. So who is a good candidate for deep brain stimulation? The latest FDA guidelines will allow us to operate on patients with at least 4 years after diagnosis. So you can be operating on someone who was just diagnosed. There is really no need. You can still try medications. But at some point, if there are many side effects with the medications, then if the patient has been diagnosed for more than 4 years, and if the medication is causing side effects for at least 4 months that you cannot control by changing different doses, then the patient is a good candidate. Who is also a good candidate? Someone who has good response to the medication. So if you have good response to the dopamine, that means that you're going to have good response to the electrical current that we're trying to give you. And also, patients who have symptoms that are bad enough to interfere with daily activities. Because if you have a symptom that is really not bothering you that much and you do get brain surgery, you're not going to be happy because you didn't get cured and you didn't get much better because you continue doing what you were already doing. So we need patients to be a little bit incapacitated. Who are not candidates? Who's not a candidate for deep brain stimulation? Patients who have a lot of balance problems. So patients who are falling a lot. Patients who have speech problems, because the DBS is not going to get this better and can actually get it a little worse, the speech, slurriness of the speech. Patients who get a lot of confusion, disorientation, or that have already dementia. Patients with psychiatric conditions that can get even agitated. Patients who were not sure about the diagnosis. That is the worst decision to make, right? If you don't know if the patient does have Parkinson's, then you shouldn't be referring them for surgery. Or patients who have another health condition that will interfere with the treatment because of a hemorrhage or cancer or something that's going to make things more difficult. So this is a little bit, a lot about the surgery itself. So this is what I was saying. We choose, so you see how big the brain is. We choose a tiny part. where we put the stimulator. The stimulator only stimulates a tiny area of the brain. You see it in red, okay? The day of the surgery, they put a metallic frame around the head, and we introduce different needles to record from the areas around where we want to put the DBS, to listen to the neurons and make sure that we are where we want to be. This is an example of what happens in the operating room. You're going to see a number in pink here. And that means how much voltage I am giving the patient in the operating room. And then at some point, you're going to see that the number is more than 2 or 3, and the tremor stops. Okay? So in the operating room, we make sure that we are able to stop the tremor or the symptoms of the patient. Okay, so besides the medications and besides the deep brain stimulation, the mainstays of treatment also depend on the patient. The main one, to me, is physical therapy. So if you have a neurodegenerative disease that is affecting your mobility, that's affecting your ability to stand up and walk and do things, you have to keep your body strong, because the more you stay in a chair, the more the condition you're going to get. So physical therapy is very important if patients are falling, if the mobility is reduced, if the patients have difficulty turning. So speech pathology is another important part of the therapy, because patients usually have slurriness of the speech, the volume of the voice is decreased, and they have difficulty swallowing and sometimes can choke with food or liquids. So speech pathology is a good specialty that all patients should be evaluated by. And they help them swallow better and make the speech a little more loud. Remember to speak louder and articulate better. Other types of therapy are occupational therapy, where they teach you specific skills or how to strengthen the ability to do specific things, such as in this case, getting out of the car or having better dexterity, driving to maintain that ability. In general, exercise and mobility are good, but the specific activities have demonstrated to be extremely helpful in Parkinson's, and those are specifically Tai Chi, dancing, and boxing, because they are pretty safe for the patients and because it helps them make bigger movements, wider movements, and maintain good range of motion. So what is the prognosis? As I was saying, it varies from person to person. It's difficult to give a general opinion about Parkinson's disease because every patient is different. You could have patients who progress very quickly in 3 to 4 years, and patients who have had the disease for 30 years and are still golfing and doing normal activities. So it depends on the patient. But it's recommended that the patient follows up regularly with a neurologist that maintains a good lifestyle, diet, exercise, and low level of stress. The disease doesn't kill anybody, but there could be some complications from things like what I was saying, the difficulty swallowing. Patients can sometimes swallow through the respiratory airways, and just putting food in the respiratory airways can cause pneumonia. So you won't die of Parkinson's, but you could die of the complications, the mechanical complications. Injuries due to falls, okay? When a patient falls and breaks a bone or hits their head, then that can lead to a hospitalization and to getting some infection, but the patient didn't die of Parkinson's, but of a complication due to the Parkinson's. So here there are some resources to learn more about Parkinson's.